Well, thank you for joining us tonight. I'm Shauna Riley with the Scripps Howard Center for Civic Engagement from NKU, and we are in the One NKY Center this evening. It's a beautiful view. Perhaps the weather could be slightly better, but it is a lovely facility, and we're really happy to be here. So the Scripps Howard Center sponsors these lectures. There are 6 in a series of 6. They start at 6 p.m., so it's 6 at 6. So if you ever see that, we hope you'll join us. The 6 at 6 lecture series is in its 15th season, where we bring NKU faculty into the community to do lectures that we hope are of public interest. And so tonight we are very lucky to be talking about rural health care. We have Dr. Valerie Hardcastle joining us. She's the Vice President for Health Innovation and the St. Elizabeth Healthcare Executive Director of the Institute for Health Innovation. This is why I have notes. It's a very long title. And so the Institute for Health Innovations at NKU is dedicated to improving the healthcare infrastructure of Kentucky. And so they do a lot of work with rural healthcare, but also with social work and other pieces that sort of come together to support Kentucky and our healthcare. And so Dr. Hardcastle herself is a prolific grant writer. She's published multiple books and multiple articles. I think it was over 150 in the last count that I saw, so very well published. We're very excited to have her. And she's going to be talking about everything, everywhere, all at once. For those of you who are joining us online, thank you. You can put your questions in the chat, and they'll come to my phone, and I will be happy to answer or ask them on your behalf. And with that, Dr. Hardcastle.
Thank you. Thank you very much. I appreciate the opportunity to talk to you. Before I start, I want to give one caveat, and that is as of 2 o'clock this afternoon, I feel like I'm coming down with a cold. I don't think that I'm really contagious, but if I start suddenly hacking, that's what it is. I have my safety bottle of Coke Zero over there in case I need that. But just so you know, I'm not dying, I'm just having a cold. Okay, let's get started. I just want to get a sense of my audience here. How many of you live in either Cincinnati, Boone, Kenton, or Campbell counties? Okay, so that looks like just about everybody. I live in Southern Campbell County myself, so I'm one of you. And one of the things I love about living here is we actually have great health care. And I can say that not just because I'm in healthcare myself, and so I'm promoting what I do, but I've also lived in all corners of the United States, and I can say with certainty the healthcare here is really good compared to everywhere else. And what I want to talk about is our neighbors just to the south of us, because we have great healthcare, but just south of us, they don't. And the question is, why? Another question is, what are the impacts? And then the third question is, what can we do about that? Because you'll see as I go through this, there's some really interesting paradoxes about the Commonwealth of Kentucky. So let me just start with a visualization exercise. So imagine it's Tuesday morning, and you wake up at 3 a.m. with chest pain. It passes, but you're scared. The nearest urgent care is 90 minutes away on a good day, if there's no ice on the roads, but you don't have a car. Your nearest neighbor, half a mile away, might give you a ride, but she works the morning shift, so she can't leave. You could call 911, but the last time someone around you did, it took the ambulance an hour to arrive, and then it was an hour and a half to the nearest ER. So you just wait, hope it goes away. This is not really a hypothetical situation. This is a Tuesday for the people who live just south of us from where we're sitting right now. Okay, so I want to talk about 5 counties: Carrollton, Gallatin, Grant, Owen, and Pendleton. And they're known as the Golden Triangle region because they're really the counties, the rural counties, that are in the triangle that's formed between Cincinnati, Lexington, and Louisville. And I want to focus on them because in my personal opinion, they are really overlooked because they're not the eastern Kentucky that shows up in the news. They're not part of Appalachia. and I used to live in Appalachia, and I know they have severe problems, and we're all aware of these problems. But they closely resemble what's going on in Appalachia, and the question is why? Why is there such a struggle? Okay, so here is the problem. Kentucky ranks 7th in the nation for healthcare access. 7th. That's really good. Out of 51, actually, because they count DC as a separate entity. 96% of the people, almost everyone, has health insurance in Kentucky. And yet at the same time, by just about any metric you look at, Kentucky is one of the least healthy states in the country. And rural northern Kentucky is worse than the state average. So how can this be? How can we have such great health care and such unhealthy people? Okay, so maybe I have gone past where I wanted to. Sorry. The numbers here are quite stark. As I already said, Kentucky is unhealthy. 1 in 3 of the residents report poor or fair health. That's a third of the population says they're not healthy. We have 3 times the US overdose death rate on average. Kentucky is number 1 in the nation in terms of cancer diagnoses, and the rate in rural northern Kentucky is even worse. And there are 20% more premature deaths than the United States median. Still, at the same time, and this is the paradox. No, sorry. This is the paradox. We have 94%, sorry, I said 96 before, 94% of the people, residents under 65, have health insurance. And then over 65, you get health insurance. 50% of the people in the Golden Triangle area receive Medicaid or on K-CHIP. K-CHIP, for those of you who don't know it, is essentially the Medicaid equivalent for children. We rank 7th in the nation for national healthcare access. And the median cost of private insurance is right at the national median. So we're not, in theory, I mean, we all know health insurance is ridiculously expensive, but not in theory pricing people out. But the issue is that having insurance doesn't guarantee access. The reality is 1 in 8 people, according to surveys that we've done in the Golden Triangle region, have skipped health care that they said they needed. They just didn't do it. The state's health ranks in the bottom 4 nationally. 10% self-reported in the Golden Triangle region worse health than Kentucky's already really poor average. And the cancer, overdose, and heart disease rates are still rising in these counties. So even though they have access to health care and health insurance, so they're not being priced out of the market, they're not accessing it. All right. So the question is why? And I want to talk, that's really what I want to devote the talk to. Why do we have this problem? And there are 3 root causes that I think feeds into this. And the first is that the doctors aren't there. The ratio of primary care doctors to patients in the United States overall is about 1 to every 1,300 people, which is still pretty high. In rural northern Kentucky, it ranges from 1 doctor for every 2,200 people in Gallatin to 1 doctor to every 3,650 people in Pendleton. That's 2 to 3 times the national gap. But actually, primary care is the easy bit. The real shortage in the Golden Triangle region is mental health care. Nationally, there is 1 mental health provider for about every 300 people. In Owen County, there's 1 for every 1,890 people. That is 6 times the national ratio. And then the additional problem with mental health care is that generally you don't just walk in once and get treated and leave, like you might with a sore throat or something like that. Mental health recovery, whatever your challenge is usually a long relationship. It requires trust, built up over time, with someone who knows and understands your history. And when there's almost no providers, and I don't have data on this, so you'll just have to trust me, there's very high turnover rate for mental health providers in rural northern Kentucky. For the few people that are there, that relationship just doesn't exist for most people. And it's about to get worse because Kentucky hospitals, I hit something I wasn't supposed to. Kentucky hospitals right now have vacancies for 12% of their entire healthcare workforce. More than 15% of the nurses in the state are 55 or older, which means they're heading toward retirement. So that number is about to get much worse. The state has estimated we need over 32,000 additional registered nurses by 2029, which is not that far away. 32,000 to meet demand. And obviously, I could just throw this out there, our pipeline is not keeping up with that demand. In northern Kentucky specifically, where we have great health care, nurse turnover runs at nearly 18%, which means if you do recruit someone to health care, you lose them often within a year or two. Okay, root cause number 2, getting there. And I'm going to approach this challenge with taking Owen County as an example. So Owen County is 350 square miles. It's a bit bigger than Kenton and Campbell County combined, if you cannot visualize what 350 square miles is. But just over 11,000 people live there, instead of the 200,000 plus that live in Kenton and Campbell County. In that huge space, they have no hospital. The nearest emergency room is, under normal conditions, between 45 minutes and an hour away. If there's ice, it's normally about 90 minutes. EMS routinely takes about 90 minutes to get to the patient and then get to the ER. Additionally, in Owen County, there's no Uber, there's no Lyft, there are no cabs, there's no bus system. There is a Medicaid-supported transportation system, but it costs $3.40 a mile, and you have to schedule it in advance. So the system doesn't help you if you have an emergency or an emergent situation. And the distance to any specialist means that just a simple round trip could be $40 or $50, which for a family on Medicaid is not a small thing. It also means for that whole ride out there, your appointment and your ride back, you're not working. So you're not earning the money to be able to pay for your bills. So when we did surveys with residents, we found that they normally travel about 60 minutes each way for a medical appointment. So just think what that means for someone with an hourly job. First, you have to have a car with a tank full of gas. You can't just slip out for an hour. The doctor's appointment really means a full day gone and a full day of lost wages. So most people just don't go. It's not worth, do a cost-benefit analysis, it's not worth it. On top of that, less than 6% of Owen County has 1 gigabyte broadband. Only 2 out of 3 residents even have basic high-speed internet. The county is hilly, so those hills block cell phones signals. And I want to say, I live in southern Campbell County on a farm, and we don't have cell phone coverage out where I live. And I'm just going to do an aside because there is an assumption that everyone has access to the internet now, particularly in healthcare, because you refill prescriptions online now. You get appointment reminders by text. You have telehealth visits. You have patient portals. If you don't have the internet and you don't have reliable cell phone service, you are essentially locked out of the contemporary healthcare system. And then, just to pile on, Owen County does not have a food pantry. There's no homeless shelter. There's no emergency housing. There's no recovery housing for people leaving treatment. They've got a treatment center there for women, and it's large, holds about 1,200 people. But if you graduate from the residential treatment facility and you don't have a family to go to, or you're not from there, there's literally nowhere for you to go. They just put you out on the street, literally, in the middle of Owen County. And then you've got to hitch your way to somewhere. Reason number 3, the foundation for health. So we know from decades of public health research that the biggest predictors of your health aren't what happens in the doctor's office. It's what happens before you ever walk through the door. It reflects your income, your education, your housing, your stress levels, and the neighborhood you grew up in. These are known as the social determinants of health. In rural northern Kentucky, all those baseline conditions are in very rough shape. Kentucky ranks 47th in the country for poverty, and rural northern Kentucky is worse than the state average. The median income in these counties falls below the state median income, which is already low compared to the national income. Only 12% of working age adults in that region have a college degree. The national average is 38%, which is actually pretty high, and Kentucky as a whole is making good gains in that direction, but that region is being left behind. But that gap, 12% versus 38%, is not just an education gap. It's a health gap, a wage gap, a life expectancy gap. Everything kind of flows from that. But I want to talk about the children in these counties, because that's where you really see the future of this region being written. About 60% of the students in these counties qualify for a free or reduced price lunch. More than 5% of the kids are in foster care. I know most of you probably don't think about foster care that much, but that is 10 times the national rate for foster youth. Unfortunately, more than half of the foster children cannot be placed in a foster home. They don't have placements. There just aren't enough of them. So then they're placed in group facilities. But of course, they don't actually have any group facilities. So they end up in places like an abandoned warehouse or an old hotel. Or they're placed out of county, away from their schools and the few stable relationships that they might have had. And these numbers don't even count the number of children who are living with a grandparent or a neighbor, or they're couch surfing between relatives, because they're not in the formal foster care system. They're not counted anywhere. They're just kind of quietly unstable. The KIPP survey, which is a survey that's done every 2 years in the Commonwealth, covers about 22,000 K-12 students across the region. 1/3 of them score at risk for poor academic, social, and interpersonal outcomes. 1/3. And these are not just children on a trajectory toward poor health, because the research is clear. Childhood adversity, trauma, instability, poverty, exposure to substance misuse is one of the strongest predictors that we know of adult health problems right now. So we are watching a health crisis of 2040 being created right now. So what we have really is a perfect storm. Because the problem is these 3 factors don't just add up, they multiply. No providers means people don't get treated. Untreated illness compounds into disability, job loss, and poverty. Poverty means no car, no ability to travel to the next county where there might be a mental health provider. No mental health support means the trauma that the children are absorbing has nowhere to go. Traumatized children become adults in crisis, and there's still no providers. Each wall makes the other walls higher. This is the challenge. It's everything, everywhere, all at once. But the good news, if there is any good news here, is that I think this is also a map. If you know where the walls are, then you can work on taking them down. So I want to talk a little bit about what we're actually doing there to make a difference, what we're trying to do. And I'm going to talk about it in the way I've done it. So this is not a policy exercise. but it's just kind of a series of moments of where we figured something out that looks like it might work. Trial and error. So the first rule, wait a minute, I think I've gone too far. Nope. The first rule is show up. When NKU's Institute for Health Innovation started working in these counties, the first thing we learned, which is something you already knew, something you know, you can't work with people who don't trust you. And trust in these communities, like any community, doesn't come from a press release. It doesn't come from a grant announcement. It comes from showing up over and over again to the schools, to the judge executive's office, to the churches, to the community organizations. The conceptual framework we use says the goal of healthcare isn't just to make services available, it's to expand what people are actually able to do and be. And that distinction matters. A hospital 3 counties away technically exists, but if you can't get there, if you can't pay for it, if you don't know it's for you, it might as well not exist. So everything we do is oriented around the question, what do people actually need in the place they actually are, in a form they can actually use? So the first thing we want to do is catch the kids before they fall. So for a while, back when the federal government was still providing grant money for this, every fall we would screen high school students for substance use risk, not to punish them, but to find the kids who are already in trouble or starting to get in trouble and connect them to help before it becomes a crisis. Now, I do want to say, and this is just my niggly aside, but it shows this huge disconnect from what goes on in DC and what happens in Kentucky, because this funding was taken away before we had a change of regime. So it doesn't have anything to do with Trump. But the next call for proposals for the series of grants that we've gotten to work there, they were thinking bigger, which is fine because a lot of the grant receivers were like me. We've gotten several over years, and so they're like, okay, now we need to grow this. So their brilliant idea was, all right, you need to build partnerships in the county, which I am all aboard with partnerships. Unfortunately, they specified the partnerships we needed. We needed to partner with the food pantries and the public transportation system, among others, to build this community. And I kept trying to explain, we're in these communities because they don't have the food pantry or transportation system. If they did, they would not be in the crisis that they're in. So, no more funding for us. But back when we could do it, we screened everybody, and I believe they're continuing it now without the grant funding. We've also worked to expand what's taught in the classroom. You all look pretty young. So, when I was coming up through high school, there was a Just Say No campaign, which fell flat on its face because anyone who knows kids, if you say you shouldn't be doing that, that's the first thing they're going to try to find out why they shouldn't be doing it. So that approach doesn't work. So what we've tried to do is bring real education to the classroom, explaining what addiction really is to the best of our ability, what science tells us it is, what happens to your brain, what the recovery looks like, how to ask for help. And then in particular, there's a program in Carroll County that I'm very, very proud of because it's one that's, I think, made a huge difference. And that is for students who are already in trouble. Most of them have they're under serious suspension or they've been expelled. We had a couple who were sentenced to on felonies, so they were not just going to a detention center, they were on their way to prison. These are high schoolers. But we worked with the county to have an alternative program based on moral recognition therapy. The MRT, as it's known, is actually a program that was designed for people in jail or prison. And it worked on individuals' essentially understanding of themselves. It's a series of structured conversations and exercises that takes, if you work on it, it takes about 8 weeks to do. to think about how you make decisions, how your decisions affect other people, and kind of how to develop a sense of moral reasoning that leads to somewhere better. And there's a version of it that you can use on youth, and the kids would then participate in this program as opposed to going to jail or prison, where not much happens there in terms of personal development. There's also a very similar program that we help fund that runs in the county detention center as well. And so the idea is that the same child who ends up in detention didn't just make a wrong turn on one bad day. There's a longer story, and you have to engage with the story. And just to give you one example, because many of these children come from very unfortunate circumstances, right? And so there was one child whose father was in prison for drugs, selling drugs. He brought a gun to school, which is a big no-no, and he was getting expelled. He too apparently was dealing drugs. I'm saying apparently, I don't really know, but he seemed to be either dealing drugs or on the path to dealing drugs. And he was also very disconnected from everyone else, as you can imagine how it would be, because he'd grown up with dad in prison, and there was a life that he knew that, I'm presuming, was very different than the lives that we know. By the end of this program, he was interested not only in graduating from high school, but going to college. And I can tell you right now, he's working and going to college. And so this program made a big difference. And it's made difference to the other kids there, and part of it is all the youth in these programs. I mean, this is a group thing, so they are building bonds of support as well. So they don't feel, each of them doesn't feel as isolated and like it's only me that are having these struggles. And I am happy to say that this program has continued despite the fact that we were unable to partner with the public transportation system and the food pantry to keep this program funded. Okay, the next thing is to meet people where they already are. 90% of people, adults in Kentucky, say that religion is an important part of their lives. 9 out of 10. That's not a statistic that you encounter in most of the public health literature. It means that for a lot of people in rural northern Kentucky, their most trusted institution in their lives is not a governmental agency, it's not a hospital, it's their church. Their pastor knows their name, their congregation has watched their children grow up. When something goes wrong, the church is where most people are more likely to feel, say they feel safe. So what do? You work with the clergy. Not to be therapists, but to recognize the signs of when someone's in crisis and know how to make a warm handoff to professional care. We also train peer support specialists to run recovery groups in the church basements and in fellowship halls, because that location sends a message. This is not something shameful. This is just us being in church, taking care of each other in a place in which we all belong. So again, it's about trying to make people feel welcome in their own community and to help them understand that this is a group project that we're engaged in. Picking up on that, we have adopted a no wrong door approach to care coordination. So just imagine that you're someone in one of these counties who's finally decided that you want help with substance use disorder. That's a fragile decision for most people. It could just dissolve by the next morning. But now you find out to access treatment, you have to navigate 5 different agencies, each with their own intake forms, their own eligibility requirements, their own waiting lists. One will help you with housing, but not your substance use. One will treat your addiction, but they won't accept your Medicaid plan. One can help your kids, but only if your kids are already in the foster care system. So people just give up. It's too hard, it's too complicated. And they don't have the internal resources to be able to manage that complex process, which you're dealing with an extremely disjointed system, as I've already indicated. So they give up, not because they don't want the help, but because the system is designed for people who have energy and resources to fight through it, and they don't have that. So our response is to say, whatever door you walk through, we want to be there for you. we'll get you to the right place. And so what we have done is we've hired dedicated care coordinators for the county. These are people who know every resource available. That's their job, everything from where you can go to get food, to who's donating what when, to how to get access to all the health care in this entire region. And everybody knows their number. We've got it posted in the pharmacy, in the grocery store, the police department has, the fire department has it, social services, everybody's got it. And most importantly, people have it. And so because word of mouth is often how people find things out. And so their job is just to help people navigate the system. You call us and we'll help you for as long as you need, for as much as you need. And the people who do this, I want to say, are incredibly dedicated. You would not believe what they do. One of them, Shanna Osborne, ended up having 650 texts with one client in the space of a month about getting her into recovery treatment. And that woman, I'm happy to say, ended up in recovery. She is stable, and she returned home. So it's a great success story, but it takes a lot of one-on-one engagement and patience and, well, frankly, a lot of time spending on hold with parts of healthcare around the Commonwealth. But the point is, their job is to make sure you actually get the service you need, not just a piece of paper with a phone number on it. And then we set up a group where we have weekly meetings across a virtual table, because it was like a Zoom meeting, with parole officers, social workers, public defenders, and the care coordinators. And so we're all talking about the same people, because people in detention, especially when they're getting released, are some of the most vulnerable people you can find, trying to problem solve. And a lot of the problems we're trying to solve are those you hear them and you go like, what? So here's an example. If you were sent to detention for something connected to substance misuse, generally speaking, when you're released on probation or parole, you have to undergo random urine checks to make sure that you are not consuming the illicit substance. Okay. Well, where do you go to get a urine check if you live in one of these counties? You come up here. It's an 1.5-hour drive. If you live in Owenton, most likely you're working in Frankfort. So you have to leave your hourly wage job that you could get being a detainee who's now on parole, drive all the way up here to pee in a cup, to drive all the way back there so you can go back to work. Your boss doesn't like it because he hired you to do a job. You don't like it because that's 2 tanks of gas and it's a whole day's worth of work not to do that. And we had somebody who ended up going back to detention because he just couldn't manage being on parole, even though he was being successful by all the metrics. So that's one example. Another example is the judge down there gets to decide if you're adjudicated to treatment as opposed to detention. The judge gets to decide where you enter treatment, which is okay, unless, for example, you're sent to a treatment program where part of their therapy is a lot of physical exercise, and one of the ways they do that is you have to walk 5 miles a day from where you are to a group meeting, and that works too, unless you have severe arthritis in your hips and back, and you literally can't walk that far. So these are questions that we all work together as a group to try to solve, because these are problems that, on paper you don't think they would arise, but it just arises out of human frailties and people not always thinking everything through. Okay. And then the last thing I want to talk about is you don't have to be afraid of making stuff up, right? You don't have to just use the tools at your disposal. So the first thing I want to talk about is therapeutic transportation. I've already yammered on a lot about how long people have to travel to get to healthcare in those communities. That's really downtime, but it's downtime we can use. So we have trained peer support specialists, and these are people who are certified by the Commonwealth under a program that we started. They can do it online. I'll talk more about that in a minute. They get certified by the state. We hire them back. They have a car, and we pay them to drive people, our own little cab service, drive people to where they need to go. But on the way there, and when they bring them back, they can engage in a therapeutic conversation. So it's not wasted time. It's time when people are receiving important counseling from people in their communities who know what's going on there and what it's like. So our people who engage with the peer support get 120 minutes of real therapeutic conversation happening on a 2-lane road. And these people drive a gazillion miles. I mean, literally thousands of miles every 6-month period, which I'm happy to pay for with the grant money I have, because that means that those people are getting good care. And the results are striking. People who receive peer support services have significantly fewer hospitalizations, and they're 18 times more likely to use medication treatment for opioid use disorder than those who don't. 18 times. And medication assisted treatment is often a really good way to start combating that type of substance use disorder. The second innovation I want to talk about is telemedicine in a parking lot. So I've talked about how people don't have reliable internet in their homes. In partnership with North Key Community Care and a grant that we got from, of all things, USDA, but I'm good at scrounging money, we started a laptop lending program. So North Key Community Care is the community behavioral health provider, and they would love to have more people in Owen and Carroll and all those other counties, but they can't find the therapists to hire. More on that in a minute. But they can do telehealth. And so people can borrow a laptop, drive to the library, which does have internet, sit in the library's parking lot, and have a one-on-one therapeutic encounter with their provider using the laptop that they have been lent. We also got, and this stuff is like, I didn't even know this existed, really cool equipment to put in all the schools and in all the health departments in all of those counties. And anybody can come in then and get, we worked out a deal with St. Elizabeth Healthcare, can have an appointment, an e-appointment with St. Elizabeth Healthcare. And this is important because, you know, some of it has to do with kids. If Johnny has a sore throat, well, you got to call mom, who drives an hour from her work, to get Johnny an hour to the doctor, where the doctor says nothing's wrong. Either bring him back to school and go back to work, or give up for the day. It's a whole day wasted for a doctor who could say, kid's fine. And so what I discovered is you can have otoscopes and the thingy that you use to look down your throat connected to the computer. So the people in St. Elizabeth get a visual of what's going on. They can also record, you know, vital signs, and they get it. So they can do pretty sophisticated diagnostics. And so not only is that good for the kids and then the parents of the kids, but then we can have community members who otherwise don't have access just go to the school and have an e-appointment. And it also works for teachers and other people who work at the school. If they're not feeling well, then they can just go there. You can also go to the health department for the same thing. It's not elegant, but it works. And it also reaches people who maybe otherwise would get nothing. And then the last thing I want to talk about is building the workforce pipeline. This is the long game. Because the research is clear that the single best predictor of whether a healthcare provider will practice in a rural community is whether they grew up in one. So we're trying to do something about that. So we have programs where we bring high school kids from the region to NKU, to the cadaver lab, where they can look at dead bodies. Apparently that encourages people to go into healthcare, although usually have one person faint with each trip. We have a retired ER doctor who talks about emergency medicine. She's a very exciting presenter. We have mannequins that they can work on, and they learn how to splint and do things with blood, and it's all very cool and hands-on. We run simulation center field trips where middle school people can practice in our mock hospital setting. We run summer camps on this. We're basically trying to make sure that the kids in the Golden Triangle who are interested in medicine or nursing or social work know that those careers exist for them, that NKU is a path to get to them, and that there are jobs waiting for them when they get out back home. And I will say that we are beginning to see modest improvements. So we've seen a 26% increase in the number of students who are in the BSN program from these counties in the past 2 years. So it's a long process, but I think it's making a difference. Additionally, for a couple of grants that we have gotten that are still working, our students in social work, addiction services, and counseling are eligible for $7,500 in stipends when they do their field placements or when they work at an underserved area in our region. So basically, I'm using grant money to bribe people to give it a try, and also to help with their bills because we know it's very expensive to go to school. And we're hoping that as they work in an underserved area in the region and they get their stipend for $7,500, not only are they learning their professions and their communities, we're hoping that they'll stay there. We're hoping that they'll see the value in doing the work there. So in closing, what have we learned? First, health insurance is not health care. It's a necessary but not sufficient condition. You can have the card in your wallet, but no realistic way to use it. It's a policy that only focuses on coverage while ignoring the structural realities of rural life, and that's a policy that's going to fail people. Second, health is not a medical problem. It's a transportation problem, a broadband problem, a housing problem, an education problem, a poverty problem. A doctor can prescribe medication for high blood pressure, but if you can't afford the copay, you can't get to the pharmacy, you're working 3 jobs to keep the light on, that prescription means very little. You can't treat health in isolation from everything else. Third, trust is not given, it's earned. And in communities that have been disappointed by institutions many times over and over, earning it takes longer than one grant cycle. The most important thing we did in rural northern Kentucky is we show up when we said we would, and then we show up again and again. And there's no shortcut for that. Fourth, innovation doesn't have to be sexy and elegant. Telemedicine in a parking lot, counseling in the cab of a truck, peer support groups in a basement. Those aren't solutions that anyone would come up with, if you're sitting around a conference table. They're not elegant. These are just solutions that grew out of listening to what people needed and just refusing to wait till you had the perfect answer. And finally, these problems are hard, but they're not hopeless. And I want to be clear about that. Our rural health disparities seem intractable, and the forces that are driving them are deep and entrenched. But I don't believe they're too deep and too entrenched to move. I've seen it move. Individually, one person at a time, slowly, unevenly, imperfectly, but it can move when people commit to it. And so the title of this talk, Everything, Everywhere, All at Once, was meant to describe the problem, but it also describes the answer. You have to show up for everything. You have to prove you're reliable. You have to work everywhere: schools, churches, courts, clinics, parking lots, truck cabs. And you have to do it all at once, because everything is connected to everything else. These communities, our neighbors, deserve that. Kentuckians deserve that. So thank you, and I'll open it up to questions. Yes, sir.
So the long-term solution is putting more healthcare providers in these counties. The things that you talked about, say it's a start, but how do we get it's imperative. If I train a lot of nurses here in northern Kentucky, they're going to stay in northern Kentucky because that's where the jobs are. How do we get those people back to the counties? Do they work in the counties?
Right. So part of it is, and we have been working with the College of Health and Human Services at NKU, is to get more placements with people in their counties. So what happens often, particularly in nursing, is you do your practicum somewhere, St. Elizabeth Hospital, you go across the river, and then they hire you because they're desperate for nurses. But if we can get people placed in the clinics in rural Kentucky, and now we've got practicum there as well, they'll get snatched up there. And a lot of people want to work in their communities. It's just, you got the job offer here. So, yeah, and you got bills to pay. And so it's building, you know, building the whole system kind of at once. So you have to start small and continue to grow it. Yeah. Yeah, that's a challenge, but that's kind of the best answer I have right now. Yes, sir.
Yeah, one of the things that I've noticed is that some of the hospitals in the tri-state over the years have built these satellite sites throughout the area. And I was just wondering if you had any thoughts on why they don't go out into the rural areas of these satellite sites.
Yeah, so St. Elizabeth Healthcare actually had a hospital in Owen County. But it goes back to the problems that I was talking about, is it was not utilized. And it wasn't utilized not because people didn't need it, but because they've been trained not to seek health care. Because it was just too hard. They don't know how to access the system is disjointed, so they literally wouldn't go to the hospital in their own backyard. So St. Elizabeth finally had to pull out. Now, slowly things are starting to come back as people are, in effect, starting to demand more health care. And a lot of it, I have to say, comes through the school system. So we've got our telehealth program there where people can access health care, and that's being utilized. It's being utilized from the health departments. But then Triad Health Center also now has a health clinic opened in the Owen County schools. So it's like a full doctor's office there. So I think with that sort of infrastructure, St. Elizabeth might be able to come back now and try again with some type of hospital type organization there. So I think that the issue was they don't use it. They need it, but they don't use it. Yes, sir.
What kind of support are you getting from the counties, from Frankfurt? Are you seeing any roadblocks, or are there
No,
element to this?
Yes. No, actually, the Commonwealth has been extremely generous and cooperative. So some of what I'm talking about now was funded through an abatement grant. So for those of you who may not know, Kentucky was awarded an unbelievable amount of money from the opioid crisis. And what Kentucky has done, among other things, is to create a granting program where you can ask for sums of money to do something in communities. It's very broad, but basically they want to use this to help communities with substance misuse. And we are fortunate enough to have one of those grants, and that right now is what's paying for our therapeutic transportation system and a couple of other things in the counties right now. But they're on it. Yeah. And actually, I'll just plug NKU. We're really lucky because my organization also is evaluating all of the Medicare 1115 waiver programs. I don't need to go in those weeds for you, but basically we're hired to evaluate things in Medicaid and Medicare for the state. And the reason we're hired is because Louisville and UK, which would be the two places you would think most likely would be hired, they're conflicted out because they have hospitals, and so they're providing Medicare services, so they can't evaluate themselves. But what that means is now we have really good connections with the people in the Commonwealth, and for people who spend much time in politics, it's usually a matter of who you know. So it's been a good partnership for NKU, I will say. Anyone else?
Well, thank you for your time this evening. And thank you to Norse Media. These are our students who are in classes, and their glorious professor who is out here streaming so that folks can watch at home and or record it for posterity or later viewing. If you enjoyed what you heard tonight, our next 6 at 6 is on April 7th. It's called Politics at Play, How the Olympics Serve as the Front Line for Geopolitical Theater. It's on NKU's campus. There's free parking. and we hope you will join us. So we'll see you on April 9th, hopefully. All right, thank you so much. Good night.